Are they coming back for care because they're better and they just want to maintain that? Or are they coming back for care because it's flaring up again? If it's flaring up again, you didn't fix them. I hate to be the bearer of bad news, but I think chiropractic can do better than that. I think we can actually fix them of their problem by addressing the posture along with the stuck vertebrae. Why would you address, it's like saying this, oh, they have a bad knee, so let's just work on that one knee. That doesn't make sense. A bad knee, we all agree, leads to a bad back because you alter the way you walk, and that's going to affect your spine. And if you don't address the back, now guess what's going to keep coming back? The knee problem. And then sometimes, if you look, 36% of the time we find that the bad knee, the one who's most painful, is not as degenerated as the opposite knee. Why would that be? Because people shift the way they walk to keep the pressure off the bad knee, and it eventually starts to affect the good knee. So if you're using pain as your barometer and the good knee starts feeling better, they're going to start having problems with their bad knee or the good knee, whatever way it gets confusing. Why don't you treat both knees? Why don't you treat both knees and the back? Why don't you treat everything connected to that body part and correct it? That's what a functional doctor would do. A doctor uses functional, not functional medicine, which I believe in tremendously, but functional physical medicine, meaning addressing why the problem's not working, not just getting rid of the symptom. It's a more effective, more elaborate way to treat them. It's going to mean a more elaborate care plan. It's going to mean a more expensive care plan in your office compared to your other care plans, but not compared to if they do nothing about it or if they go to a surgeon. Because doing nothing about an orthopedic problem ultimately leads to surgery. And the cost of surgery blows everything we do way out of the water. I'd be willing to argue the cost of our care plans don't even pay for the anesthesiologist for the surgery. And the surgery rates are high failure rates because they're actually cutting out tissue, which creates more scar tissue. So what we've done is we've used our functional physical exam, assessing the 28 muscle groups that are associated with upper cross and lower cross syndrome, and measuring that on the re-exams, which we do every 2 weeks. The reason we do that is we want to make sure the patient's actually getting better. And if it's not getting better, or if they're not getting better, we can alter our program to fix that. So we do this every 2 weeks, and we estimate in the beginning to the patient when they're going to be done. We let them know that in advance. It's an estimation. Could we be wrong? Yes, we could, but the more you do it, the better you get at it. So we estimate ahead of time. Why is that important? We want to let that patient know we're going to discharge them. We're going to get them to a point where they're corrected. We're going to measure every 2 weeks to make sure they're getting there. At those moments where we do those re-exams and re-measure, the patient's going to be aware of their progress. Their symptoms are going to go away in the very beginning part of the problem, probably in the first third of the treatment. But what will happen is we'll continue getting that patient to come in based on functional, scientific, measurable data. And you share this with your patient. Now, if you're doing this as a chiropractor, you need to do this with your patient. Let them know, this is where you're at. This is where you started. This is where we're trying to get you. This is where you're at. But I feel great. Yeah, that's because symptoms go away here, and you're here. But what you said to me in the beginning, you wanted to get here. So we measure function in relation to activities of daily living. So when somebody comes in with that bad knee, what can't you do because of this bad knee? I can't climb steps. I can't run. I can't lift my grandchild. I can't do this. I can't do that. And then we quantify it, measure it. And then we say to the patient, okay, each re-exam, how are we doing? That measurement, last time you said it was here, where's it at now? I'm able to do this much. What number would you assign that? And now we're quantifying the functional abilities based on what we're also seeing from the limitations of the muscle structure. So what we're creating is long-term goals and short-term goals. The short-term goals are to correct the muscles. Some muscles are going to be too tight, some muscles are going to be too weak. Every time there's a tight muscle, I can guarantee you there's also a weak muscle. The weak muscle is causing the tight muscle. The tight muscle is producing the symptom. If you only treat the tight muscle, they'll get temporary relief, but it will continually come back. If you treat the tight muscle plus strengthen the weak muscle, the muscle that was tight will tend to not get tight in the future. That just makes sense. And to do that, we see the patient 3 times a week, from beginning to end. How long is our care plans? Depends on the patient, depends on the condition. It's anywhere from 4 weeks to 6 weeks to 8 weeks to 10 weeks to 12 weeks. Where do you get that from? We look at different things, like for example, if you were to hire a personal trainer and say, can you get me in shape? They would say, yes, but I need a couple conditions followed first. What would that be? I need you to guarantee that you're going to do at least 3 times a week with me. What if I don't? Then I'm not going to get the result and you're going to be mad at me. So can you do 3 times a week? Now, when you say this to a patient, you don't say 3 days a week. You say about 4 hours a week. 4 hours a week, that's all? Yeah. See, we have to have you come in for about 1 hour and 15 minutes at least 3 times in a week. That adds up to about 4 hours. If you can do that, we can help you. Can you commit to that? Yes, I can. Okay, good. And then the amount of time we need to do that, the length of that duration of those visits at 3 times a week or 4 hours a week would be the same as if you were going to work out. If you were to hire a personal trainer, ask yourself this: how long would it take that personal trainer to get you in shape? Now, some of you are going, I'm in great shape. I don't need to hire a personal trainer. Fantastic. But that's not who's walking through your door. Who's walking through your door is somebody who has a compromise. How long would it take a compromised person to get in shape? That would be somewhere between 4 on the very short end of an acute injury of a very healthy person to 6 to 8 to 10 to 12 weeks. Plus, Medicare says an outpatient physical therapy program should be 90 days or less, which is 12 weeks. Plus, the average muscle cell lasts about 12 weeks. If you look at it, there is science behind all this. And what we do is we try to get these patients better in less than 12 weeks, and we make that estimation based on the condition of the patient, the age of the patient, the overall physical activity, and the seriousness of their condition. So when we put all that together, we're making care plans that are based on science, not based on, I decided to cut you down 2 times a week. How come? Because you're complaining about coming in 3 times a week. That's what most people do. And when they start complaining about 2 times a week, oh, what a coincidence, we're going to cut you down to 1 time a week today. That's not science. And that's feeding into the symptom is the problem. And that's feeding into the patient going, they just want me coming in here to make money off me. They're just trying to treat me. Where did that come from? I can tell you, people who are opposed to chiropractic and want to see chiropractic not do well because they eat into their profits of a certain profession that sells remedies for pain, they don't like chiropractic. So they tried to make us look dangerous. When I graduated school in 1991, cover of Time magazine, chiropractic linked to strokes. Like, that's not good. I just started a career, and the cover of Time magazine says what I could do could cause a stroke. So I looked into that, and I did my research, and I found out that in the article it even said it's a very, 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 very slim chance, very remote chance. In fact, you have a higher chance of having a stroke when you get your hair cut than you do from going to a chiropractor. Then they said a plumber has a higher chance of having a stroke working underneath your sink than going to a chiropractor. And in fact, the president of the American Heart Association said taking a baby aspirin has a higher chance of causing stroke than a chiropractic adjustment. That one didn't work too well. But what did work well was you shouldn't go to a chiropractor. They tend to treat you when you don't need it. And there you are saying, oh, we'll cut you down to 2 times a week today. You feed right into that whole story. So let's be scientific. What we do works. People need more chiropractic care now, not less. They need to get care plans and be discharged when they're completely fixed. That means addressing the functional component, the muscle component, and the spinal component. Not just one of them, but all of them together means a well patient that is fixed and it's not going to come back. I'm going to urge you to consider this, look at that and say, if I can educate my patients differently about what I'm doing and what my goals are and measure scientifically, what about doing a computerized range of motion every time they do a re-exam? We do that because it shows objective data, not subjective data. Plus we're measuring the strength of the muscles. Objective data. Using that to decide the care plan is way more scientific with way better outcomes than going, how do you feel today? Oh, you still want to come in 3 times a week? We don't want to do that. We want to get people well and have them know why they got well. Oh, but the patients won't come back for maintenance care. They might, some will, but they'll be referring their patients in or their friends who have a problem, and they will show up in your office when they have the next problem because they knew you were being honest with them, you got them well, and it was a much better thing to do than go get surgery or take drugs. Consider what I said today. If you like what you heard, or if you have questions or comments, or you don't like what you heard, leave a comment below. We're glad to hear them. And if you want more information like this or more content, like and subscribe.